Okay, everyone. So wonderful to see so many of you coming into this webinar today. It's my pleasure to welcome you to this webinar on the ASAM Criteria 4th edition, a brief introduction. My name is Valerie Bagley, and I'm the Chief Program Officer here at the Change Companies. This is a collaborative webinar between the Change Companies and our training division, Train for Change. The mission of Train for Change is to bridge the gap between knowledge of what works in addiction treatment and helping providers develop skills in these practices for use in real-world settings. And as a result, we're a leader in ASAM criteria training that not only increases knowledge, but builds actionable skills and moves implementation forward. Again, pleased to see over 1,000 participants joining us from all over the country. Thank you so much for caring so deeply about applying best practices in addiction medicine to the work that you do. We've had some incredible questions come in during registration, and we're really looking forward to answering many of them in the next hour. Please note that if your question doesn't get answered in today's webinar, we are available at support@trainforchange.net to answer any additional questions. And we do have members of our team standing by to answer any questions related to training or technology in real time throughout this webinar. A couple of quick things to note before we jump in here. First, that we will be emailing a recording of this webinar and a downloadable accompanying PDF summary within a day. This webinar does not include certificate or CEUs, just so everyone is aware of that. And then secondly, information provided in this webinar aligns with public information by ASAM provided at newasamcriteria.org. So provision of this information is from the Change Companies and Train for Change, but doesn't necessarily constitute an endorsement of this webinar by ASAM. Let's jump into the next slide. And without further ado, it is my pleasure to introduce you all to my colleague, Scott Boyles, who will be your presenter today. Scott is a licensed addiction counselor, a MINT trainer, and the Senior National Training Director at Train for Change. Scott has spent over 3 decades in the behavioral health field, and he's one of the original early adopters of the ASAM criteria, starting in 1991. Before he became a full-time trainer, Scott used the criteria professionally as both a counselor and a director. He's served on a number of ASAM steering committees and has also spent many years as a site reviewer, monitoring programs' application of the criteria. Over the years, Scott has trained over 8,000 people in the proper use of the criteria. He is well known for his informative, engaging, and entertaining trainings, which include practical real-world applications. So you are all in for a treat today. And Scott, I'm going to hand it over to you for our overview.
Welcome. Thanks for the nice introduction, Valerie, and welcome to the ASAM Criteria 4th edition training. I do want to make one note. There's absolutely no connection to me training thousands of people in the struggle with implementing the 3rd edition. I'm not a part of that. I just for clarity's sake. But we're going to try and just touch on some key aspects of the 4th edition of the ASAM criteria. And I'm sure a lot of you are very, very excited about this, knowing that this is just going to be an incredibly awesome training. I would love to get your hands up, and a lot of people, of course, probably came to possibly see me, or you may have absolutely no clue who in the world I am. And you may just be interested in the 4th edition. So before we get into the fun content stuff, of course, this is a webinar, and I just want to note, hey, you're on mute. But no, you really, really are on mute. So we won't ever be able to hear you, but you can't go through a webinar without noting people are on mute, right? The other thing that's key to a great webinar are polls. We're going to do just a couple of quick polls. I'm going to launch these polls, and we're going to literally give you 30 seconds to respond. So quick responses would be really appreciated. We want this thing to move because we got a ton of information to go over in the next hour. And you are killing it. My computer screen is flaming based on your response speed. at that. I'm going to give you an extra 10 seconds just because it's going so fast. Bravo. If you didn't get your response in, no big deal, but you can take a look at the results. I hope you can see the results. Almost a 50-50 on, hey, we're going to get into it, compared to the, we're waiting for direction from the state. Interesting. So thanks for your responses. And again, give you another minute to scroll through the responses in case that's of interest to you. Some folks aren't even using the ASAM criteria. Yeah, you might just be getting settled with the third edition. It's like, here we go again. All right, thank you. So we got to start out with like bravo to ASAM. ASAM killed this thing, and this is my personal subjective perspective. But as a user and training of the criteria for quite some time now, I mean, this thing it's brilliant. I think it's super subjective. It's simple, it's clear, it's concise, and it's ironically complex at the same time. It's like a really unique personality, but it's user-friendly. We used to joke about the term user-friendly in the 460-page third edition, but this thing literally is user-friendly. It's borderline linear, sequential as far as making decisions and understanding dimensions and levels of care. It's awesome. It's really awesome. Again, totally subjective, but I'm guessing ASAM might have the same subjective perspective. So again, awesome. And it took 33 years to get here. This was an evolution, a continuous improvement process. The last decade of experience, knowledge, and expertise and use of the criteria, especially is evident in the fourth edition, not to mention the criteria that was originally developed in 1991 based on primarily Cleveland criteria and NAATP criteria. So not losing sight that all of the people have been involved in this for many, many years, just laid the foundation and the growth for this thing to continue to blossom. So we're going to talk about just some basic updates. Some of this information is not brand new. It's already available out there, but just right off the bat, 3.7. I don't know if you remember 3.7 in third edition was typically called inpatient. So a change for 3.7 is now residential, medically managed residential. Historically, it was called medically monitored inpatient. What's the why on that? If you're in a 3.7 and you have needs in dimension 1 or 2, possibly dimension 3, you need medical management. So it reflects a more active participation from the medical management perspective, and also acknowledges that this is a residential level of care, which is the more common place for the delivery of services for substance abuse treatment versus inpatient settings. There's no 0.5. Hold your horses. No 0.5 in the continuum. Historically, people misunderstood 0.5 almost like it was the lowest level of care. It's like, things aren't so bad, we'll pick 0.5. The intent of 0.5 was for folks who did not meet diagnostic criteria. It wasn't necessarily the lowest level of care, although sometimes it appeared that way as part of a continuum. So what they've done is there's still early intervention prevention services, but it's not like part of this linear continuum. It's not like 2.1, level 1, 0.5. It's a separate section that's really talking about early intervention and prevention as part of a system of services rather than a level of care that we're choosing from as we're making clinical decisions for the people we serve. So a rearrangement, if you will, for 0.5. Biomedical and withdrawal management, if you recall, withdrawal management was the separate section in the book. Withdrawal management is now included in all levels of care under the designation of 0.7. So we have a 1.7 level of care, 3.7 level of care, et cetera. So 0.7 designates not only withdrawal management, but biomedical needs within all levels of care within the continuum. So withdrawal management still definitely there, but again, blended in, and also kind of noting the way the book was set up, it almost looked as if withdrawal management was this thing you addressed in and of itself. And that wasn't the intent by any means, but based on kind of the redesign, if you will, noting that withdrawal management may also include the appropriate clinical services at that point in time for the person served. So a couple of pieces to note there. As we move on, how about this? Reflecting harm reduction as a component of individualized care. So there's significantly more information and more reference to the term harm reduction. Harm reduction literally, truly meeting people where they are at, not only addressing the substance use itself, but addressing the conditions and or the impact of the substance use. So harm reduction is also noted as a way, and I wrote this down because I didn't want to mess this one piece up, gets away from prescribed goals inherent in program-driven services. So harm reduction is not just this thing, harm reduction, but harm reduction could potentially be and is this valuable vehicle to continue to understand the individualization of clinically driven services. It's almost like a flag, individualize, individualize. It's not saying all services are harm reduction, but it certainly is a nice cue to remember and give us additional structure to really think about, it's not just individualized services based on your program, it's individualized services based on the person's needs. And harm reduction, I think, really highlights that in addition to many, many other things. Updating the continuum of care, co-occurring capable across the board. And if you remember or not, there used to be addiction-only services and PPC2R, a type of service called addiction-only. They removed addiction-only in the 3rd edition. And now they're very clear that all levels of care are co-occurring capable. And then some levels of care are co-occurring enhanced. They have the ability to deal with more complex mental health and or potentially cognitive conditions, co-occurring enhanced. And there's much more specificity as far as what those levels of service include. There's more specific measures and there's more specific descriptions for what we would see in those different levels of service and types, meaning type co-occurring capable compared to co-occurring enhanced. So there's kind of what they call universal service characteristics, which might dictate for every level of care, this is what it looks like. But then they'll have service characteristic standards for co-occurring capable, or I'm sorry, for co-occurring enhanced, which are going to give you much clearer guidelines on what a co-occurring enhanced service looks like. One of the beauties that they've really added is specificity for understanding level of care determination for that recommendation, but also specificity as far as what does the level of care look like? Specificity as in, here's the dimensional information we're looking for, but now they're very specific questions. There's actually goals related to what we're looking for as a provider when we're doing the assessment in a dimension. So we'll talk more about specificity a bit later, but just speaking to a significant improvement in that particular area. We used to have 3.3 in the 3rd edition, the most misunderstood, misused level of care. Frequently, people thought of level 3.3, special populations. They thought it was either for special populations based on the federal government designation of special populations, or they thought it was a level of care between 3.1 and 3.5. It's like in the middle, so it's like 3.3. And it was not typically referenced what it was intended to be, was it was this unique level of care for people who had significant cognitive deficits that needed longer, repetitive, slower delivery of clinical services. this level of care didn't evolve, and it ended up most often looking like a psychiatric facility for that type of care. So they've removed the level 3.3 and included within the criteria, any level of care should have the capacity to deal with folks who have cognitive conditions, and that would be a part of quality assessment and individualization of service plan and clinical services to meet their individualized needs. So across all levels of care. And that's historically how we thought about it within the context of the adolescent criteria. Supporting access to recovery support systems, recovery systems, which will include recovery residents. I should have been capitalized. The criteria is added in. How do we utilize recovery residents within or as a component of intensive outpatient or outpatient? And there's structured criteria to help make decisions about recovery residents. And they've done a wonderful job identifying different levels of recovery residents. They've identified 4, which have been historically in place. So recovery residents. And the idea here, again, there's lots of pieces, but again, so many of the people we serve need a safe, structured place. Most often to get a safe, structured place, you needed to go to 3.5 or 3.7. Sometimes there was 3.1s available. But the criteria is, again, kind of evolving to saying there's lots of safe, structured places that might meet the needs of the people we serve in conjunction with the appropriate level of clinical services. And so, again, those could be combined with more intensive levels of care, or they might just be in recovery residence at kind of the minimal service delivery and participating in some types of outside support services. So recovery residences and recovery systems. This is like the most exciting thing in the world right here. I know you're riveted as much as I am, but they've differentiated the intake assessment from the treatment planning assessment. Remember, it's a lot of providers and states, it's like all you got to do is the assessment and develop the treatment plan. You got 2 hours to do it, or you got 1 hour to do it, or you need to do it in the first session. Service system designed to be the most evasive possible at times, not purposeful, but trying to gather all the information for the level of care determination and trying to write the treatment plan like right off the bat. And the ability from a time perspective was incredibly challenging, but what was happening to the engagement process of the person served was and is impacted with that also. So by differentiating the assessment or the intake assessment from the treatment planning assessment, meaning the intake assessment, really the level of care assessment. First, we're determining level of care. We're looking at all 5 dimensions and thinking about severity for the level of care decision. Based on that, we make the level of care recommendation. And to make a level of care recommendation, we've identified some clinical needs within the dimensions. The criteria supports really focusing on what's called driving dimensions. And most often these might be more serious needs in dimension 1, 2, or 3. The driving dimensions that are most severe dictate the level of care. Within that, we formulate a preliminary service plan to focus on those driving dimensions. Then based on the level of care the person enters into, whether it's a 3.7 or 2.1 intensive outpatient, there's timelines on a treatment planning assessment and the development of the treatment plan. So they've clearly delineated these 2 steps. And in the process of that, one of the many outcomes is allowing clinicians, and more importantly, allowing the person served to develop a relationship, to continue the assessment process, not under this tight time frame, and then develop the plan of care to continue. Again, that plan of care, and that additional treatment planning assessment is clearly guided but by all the dimensions, and including revisiting the dimensions and or those clinical needs, dimensional drivers that got the person into the level of care. So short version, more time to assess and develop plans of care. That's a biggie. It's also going to be a biggie systemically, because a lot of times we aren't really designed to do that. I don't know if our system is currently designed to look at those two aspects with different timelines. I think I touched most of these. I'm going to just keep moving on. I always want to wait for questions, but in this webinar format, ironically, we don't have questions. We've been talking about forever. We have a chronic condition. We've known about this for decades, and we have an acute model of care, or we have services designed to treat an acute condition. So they have really focused on developing services, terminology, language, and criteria to address a chronic condition. Again, I think it's like most wonderful, most awesome improvements. I don't know that that's the technical term, but chronic care model. So level 1, long-term remission monitoring. By the way, not relapse prevention, long-term remission monitoring. To get into level 1, the lowest level of service, diagnostic admission criteria, sustained remission. In level 1, we focus on recovery management plan, remission maintenance plan, not a relapse prevention plan, language matters, and recovery management checkups. So within the context of this, we'll come up with a brand new set of unique acronyms also. There is a recovery management plan compared to a treatment plan, and that's reviewed and updated quarterly. ASAM Criteria recommends no limits on the length of stay, almost like it's a chronic condition. No, how long does it take to address the chronic condition in 6 weeks of intensive outpatient? This again gives us structured language and support to really think about a chronic model of care. Moving on to level 1. Level 1.5 is outpatient therapy. Designation, just from the treatment planning perspective, develop that treatment plan after 3 visits, remembering that we've done an assessment to determine level of care. Once they enter level of care within 3 visits, we continue the assessment process, biopsychosocial, to develop the plan of care. Outpatient therapy, 1.5. It's a new thing. 1.7. It's a new thing for outpatient, level 1, medically managed outpatient. You shouldn't have to go to a residential treatment setting to get your medical needs met, or an inpatient setting. And sometimes that was the case, or an ER. So bringing in additional structures, service design, and staffing to offer a level 1.7, which can focus on dimension 1, 2, possibly dimension 3 issues in level 1 services. Noting if you're a level 1.7, you're probably also at level 1.5, and you're probably also a level 1. So these are not going to be separate services or separate buildings or separate providers. Usually if you can offer that highest level of care, you're going to have the infrastructure to offer all levels of care, because we're not just doing 1.7 focusing only on biomedical issues or withdrawal needs. If someone's an outpatient candidate for withdrawal management or medical needs, we could probably assume that they're functioning also at a high enough level to receive level 1 clinical services in conjunction with that based on their individualized needs. So significant changes for level 1 care. 2.1, IOP, intensive outpatient. Not a lot of difference when we think about 2.1, same number of hours, but 7 days for treatment plan development after the admission date. So that's a significant change just as far as that treatment plan development. 2.5 used to be partial hospitalization, which never made sense. Sometimes we called it day treatment, 2.5. So that's evolved into high intensity outpatient. So 20 or more hours per week. So that could be, again, that 5-day a week, what we used to call day treatment service, but any clinical service 20 hours or more per week where people are not spending the night. Also noting, just because it's an opportunity, outpatient or intensive outpatient does not need to be 9 hours or 12 hours or 10 hours. Can we stop it? It can be 18 hours, 17 hours, 16 hours, 15 hours. Again, we've historically been designed, if you're not succeeding in our intensive outpatient program that's 12 hours, we transfer you to level 3.5. Can we start considering, if you're not successful in getting clinical services you need, coming 10 hours? Can you come 12 hours? Can you come 13 hours? So again, a continuum of care within a level of care, not a continuum of care, meaning moving people from level to level or program to program. That's not new, that's old. 2.7, medically managed intensive outpatient, just like medically managed 1.7. These folks are gonna need more contact because of the severity of their dimension 1 and or 2 issues, and possibly dimension 3 needs, if those dimension 3 needs require medical monitoring, or technically, I guess the term is management. We've kind of lost the term medical monitoring, which used to be part of the level 3.7 services. So 3.1, big change. 3.1 is still 3.1 as far as the structured, safe, supported living, historically sometimes used as a halfway house setting, but it's also a place to start treatment or a place to have a nice, sober, structured, safe place while you're participating in intensive outpatient services or high intensity outpatient services. But the big change in 3.1, it used to be a minimum of 5 clinical service hours per week. Now it's 9 to 19 clinical service hours per week. So 3.1 aligns with the same clinical service hours as 2.1. And that could be a significant shift for some of the 3.1 providers. And those clinical service hours can be provided with collaborative service agreements with local providers. So hopefully this includes more collaboration. It doesn't all have to be delivered by the 3.1 entity itself, but there would be clear working arrangements, MOUs, et cetera, of who the provider is that they're working with to offer these additional clinical service hours. 3.5, clinically managed high intensity. Treatment plan developed within 72 hours of admission. A little more of a window. Some states are acknowledged and allowed for these types of windows, but a specificity of 20 hours per week. Historically, it has not been clear on how many hours of clinical services do people need in those residential settings. So 20 hours per week in 3.5. Services available 7 days a week. So this isn't Monday through Friday clinical services, and then on weekends it's less structured, but there are clinical services, and I would say available 7 days a week. And it doesn't specify you have to do this and this and this 7 days a week, but it specifies available and a minimum of 20 hours. I'm so used to saying, hey, are there any questions? But you're on mute and you're going to be on mute. So, but thanks for listening. 3.7, we think about the broad level 3 services, medically managed 3.7 residential. It used to be medically monitored inpatient. And the idea is residential for 3.7 instead of inpatient. Most service providers who are offering that level of care, most overnight service providers offering substance use services are residential settings compared to inpatient settings. ASAM, it would be really cool if you define the difference between residential and inpatient in the glossary, just a touch, unless I missed it. Level 3.7 bio, the more sophisticated in addressing dimension 2 needs, possibly dimension 1 needs, or complications between dimension 1, 2, and who knows, maybe even dimension 3. But the capacity to offer more intensive medical services, including management of IV medications. And again, this would be a designation for unique programs that had this bio capability. That's not an expectation across the board. Preliminary treatment plan as noted within 24 hours. Last but not least, level 4, medically managed inpatient. We've been saying for years, if you want to get medical management, what building do you go to? Well, most often you go to the hospital. There might be some unique inpatient treatment programs that offer the more sophisticated medical management services or potentially psychiatric settings, but more often than not, this is, we're still talking about hospital. So people are going to obviously get into this level of care with imminent need, imminent danger, most likely dimension 1, 2, potentially 3, and or a combination of the above, which is not really different than how it's historically been defined. Valerie, we're doing pretty good on time. Thank you. So we're going to touch on the dimensions, and then we're going to touch on some new terminology, and then we're going to do another poll and take some questions, and our party's going to be over. So I hope you're hanging in there. Dimension 1, intoxication, withdrawal, and addiction medicines. Addiction medicines, we'll come to that in a second. Every dimension has what's called subdimensions. And again, with the subdimensions, the ASAM criteria gives us more specificity to really think about what we're looking at within a dimension, but those subdimensions are designated as far as which ones we're looking specifically at for the level of care determination, and then which subdimensions we're looking at for the treatment planning assessment. In essence, we end up looking at all of the dimensions, but when we're thinking about level of care, there are very specific subdimensions that we're looking at, which really, again, helps us to start to connect the dots. What within this dimension is of high priority that's going to immediately impact the level of care decision. And that's really some of the guidance that these terms subdimensions offer us when we're assessing for level of care. And the subdimensions for dimension 1 are listed there. Some dimensions, we're looking at subdimensions for the level of care decision, every single subdimension. And then as I go through this, we'll see that some dimensions, they might have whatever 5 subdimensions, but at the level of care assessment, we're only looking at 2 specific subdimensions, which again really help guide us on the severity within a dimension that might impact level of care immediately. And hopefully that'll be more obvious as I continue through the slide set. All levels of care support broad access to addiction medicines. All assessments include the need for addiction medicines. It's embedded in the criteria, and that would also be an aspect of service delivery and levels of care and the capacity and ability to manage, assess, offer addiction, the need for, and addiction medicines. I guess offer and assess would be a part of that, and then manage appropriately. And it's not like everyone's going to have all these folks on staff. There might be collaborative agreements, but clear processes in place to delineate how these things happen at every level of care. Dimension 2, classic biomedical. But when we think about biomedical, what are our biggest concerns when we're thinking about level of care? Any physical health concerns and pregnancy related issues. So those would be called the driving dimensions when we're thinking about level of care. That's the primary focus for our level of care decision. Again, really help us prioritizing severity issues. Excuse me. Dimension 3. I'm so glad they turned out the word emotional. It just helps it be more clear. A lot of people got lost in the word emotional under dimension 3, which is currently in the 3rd edition. So that's one thing that's been removed. But we're looking at dimension 3, making that level of care determination assessment. What are the 2 key focuses? Do they have active psychiatric systems? and persistent disability. This isn't just any persistent disability, but this is persistent disability in relation to mental health condition, psychiatric condition, and or cognitive conditions. So those are the two primary focuses. After the person enters services, we continue the assessment process to address these additional needs. And just while I'm thinking about it, trauma, extensively expanded. I don't even know if that's the right word, expanded, because it's so extensive as far as what they've added to the criteria to think about trauma across the board. Dimension 4, remember way back when it was treatment acceptance resistance, it evolved to readiness to change, and now it's substance use related risk. So substance use related risk, which is very similar to what's now called Dimension 5, relapse, continued use, continued problem potential. So what was Dimension 5 is much closer to Dimension 4. What are we looking at for dimensional mission criteria? I'm sorry, for the dimensions and the specific subdimensions when we're assessing Dimension 4 for level of care? Likelihood of risky substance use. We're going to look at the classic Dr. David Mealy history, here and now. How worried are you when we're thinking about risky substance use? And we also might think about risk or imminent danger. And then risky substance use disorder related behavior. We left out the word behavior just to keep you questioning, but it should say related behavior. So when people use, what happens, and or what behaviors are related to the access of substances. There could be anything from theft or fraudulent prescriptions, or it could be a variety of different things. So, but really focusing on those behaviors related to substance use. Two components. Those two components are assessed to understand level of care, and then they're further assessed to define and refine the treatment plan. Dimension 5, recovery environment interactions, compared to the broad term of recovery environment. It really hasn't changed in theme, but there's a lot more specifics as far as what we're looking at in Dimension 5. And you can see the bolded bullet points, again, are specific to where our area of focus is relative to determined level of care. The last bullet, which you may note, is hasn't historically been very in-depth in the other editions of the criteria, but the cultural aspect, and they've brought that in a variety of different ways. This is just one, but that would be the additional further assessment to help with identifying treatment planning needs in conjunction with the other subdimensions. But again, the top 3 are really informing us about the level of care decision. Last but not least, and this is, I mean, when we get overly excited about the value of really what they've added to the ASAM criteria, we used to like simultaneously figure out the level of care while we simultaneously figured out whether or not they had a problem. We used to simultaneously figuring out whether or not they were ready to change before we even knew what the treatment recommendations were or what their clinical needs were. We're trying to simultaneously think about readiness to change. We were confused. I was confused. I saw a lot of confused people. Well, if everyone's in pre-contemplation, what level of care? If everyone's in contemplation, how does that affect level of care? It doesn't affect level of care. It impacts our approach and our clinical interventions. That wasn't super clear in the 3rd edition. And it was readiness to change was really somewhat tied to level of care decisions, and maybe not the clearest way. So what they've done is readiness to change is applicable across all 5 dimensions. Based on those specific issues within a dimension, we can conceptualize and understand readiness to change and how we might approach those issues and or engage the person in the process of change. And then dimension 6, after we make a recommendation and understand the level of care, let's talk about, what do you want to do? Shared decision making. Here are my suggestions. What are your interests? We might be looking at what's available, what's not available. We might look at funding. We might look at unique cultural or spiritual beliefs that might impact the level of care and or type of services. Ironically, we might even look at specific cultural beliefs that might be clear barriers to service that are completely unrelated to their desire to change their behavior, and historically might have been labeled as denial, resistance, or a lack of motivation. But the criteria has really given us a nice place to start having much better discussions about these unique things of the person served and how that impacts their choice and their ability to enter care. The other underlying foundation, and I don't think it says this in the book, this is my interpretation, social determinants of health. Social determinants of health is a key piece in dimension 6. Where do they live? What's their lifestyle? Socioeconomic issues, a variety of different things. And how might that, under the umbrella of social determinants of health, help also inform us about treatment needs, access to services? So that becomes a significant component of dimension 6. Shared decision-making, recommendations, processing, discussion, and then we decide on a level of care. So a significant change in a structure to really help engage the people we serve in a collaborative process. And not just to do that, we always talk about that, but it's now designed to support that. And historically, the design of the criteria and the assessment process within the dimensions was not designed nearly as well as what they've done here with dimension 6. I think we need 2 hours, Valerie, but I'm going to keep it to an hour. Measurement-based care, MBC, not to be confused with NBC, which is where the peacock lives. MBC, measurement-based care. And if you're CARF accredited provider, you're probably more familiar with this than some. But really understanding the needs of the person served based on validated tools and measurements. The value of measurement-based care. It can help engage the person served, not only by participating in the discussion about progress, lack of progress based on specific measurements and offer direction. It can be empowering. I can see how I'm progressing based on these measurements, which also go in conjunction with an individualized service plan, by the way. Applications, we might be using measurement-based care as part of the assessment process, part of the reassessment treatment plan update, if you will. So again, it may be very integrated with the process of understanding progress on goals and objectives on the plan of care. And it might be relative to how we think about transition, historically called transfer, but transition to other levels of care based on measurements of improvement, again, with specific tools. So it could be applicable in a few different areas. Here are some examples also to add to your acronym list. There's a lot more than this. And some of these were Siwa, cows, Sina, historically been really familiar with. Socrates, Eureka could probably be thrown in there also, which again, go way back. Some of these are obviously more specific to dimension 3 issues. Some might be more specific to dimension 4 or dimension 5 issues. We're not using these tools across the board for everyone, but we're using them strategically based on the needs of the person served and what we're trying, obviously, to measure. Risk ratings. Risk ratings, the most confusing, most misunderstood, actually more confusing and more misunderstood than level 3.3. And they've done a wonderful job of simplifying risk ratings. So basically, level of care and risk rating. They're not like separated, like you have to figure out all the risk ratings and then we got to go and figure out the level of care. It was too much work, too much confusion. People thought risk ratings equal level of care, level of care had equal risk ratings. They've removed all of that madness, unintended madness, and just connected the risk rating. Sometimes it's a number, sometimes a letter, to the level of care. It's like specific, it's like dot to dot, it's concrete, it's understandable. Risk ratings also include these new aspects. None, there's no risk, there's no issue. Or risk rating any, meaning there's an issue here, but it could be addressed at any level of care. It's not going to impact the specific level of care decision. Or risk rating eval, which means, oh boy, we need immediate eval on this issue now. There was another risk rating also related to medication. So a couple additional terminologies with that, but again, none and any just really will help simplify the process of prioritizing clinical needs within the context of the dimension. So risk ratings are really kind of more of a marker of a level of care than something that you need to figure out over here and then go figure out the level of care and try and make the two match, which has never happened in the history of mankind. It's really simplified it. Dimensional drivers, I use that term a lot already. I'm not going to touch on that. A written algorithm for the level of care decisions. Again, I don't want to oversimplify it because it's somewhat complex, but once you get it, it's somewhat clear. I don't know that I've got it, but it's much more specific as far as making the level of care decisions. It's clear. We're not putting everyone also in a box either. It's not that clear. There's still clinical judgment and all those things we know are not going to go away anytime soon. But it's very specific as far as thinking through the decision process. And there's a clear delineated decision process, hence the term algorithm, to make the level of care recommendation. Continued stay criteria for each level of care. Continued stay criteria, transition criteria focuses on the dimensional drivers that got the person into that level of care, but it's specific for each level of care. If you remember in third edition, we just had continued stay criteria, which was broadly used across all levels of care. So much more specific, and kind of short version of continued stay is, do they still need the services in this level of care to address the clinical issues that got them into that level of care? If they don't need the intensity of those clinical services in that level of care, based on the dimensional drivers that got them into that level of care, then we're thinking about a different level of care. It's really simplified in a way. There's more text, but it's much more simple because it's much more specific to each level of care and the dimensional drivers. We could do days of training on the additions around trauma-sensitive practices and the underlying components of trauma-sensitive practices, such as trauma-informed care. Cultural humility, again, foundational for how we interact, connect with the people we serve, and the design and delivery of services. And then, as mentioned previously, social determinants of health. Ironically, looking at addiction not just as a person problem, but a systemic issue, and what are the systemic needs of the person served that are going to help with their recovery process and or impact recovery process, and from a barrier perspective, and or things that might be tapped into systemically to improve the quality of services, and also understanding how that might impact the severity of their addiction and where they are at that point in their life at this particular time. It's not just because they chose to pick up. There's systemic issues, and I think biopsychosocial acknowledges that, but social determinants of health, I think is even a broader consideration and valuable consideration to understand the people we serve and the services they need. On that note, we are getting so close to the end. Just a couple terminologies. I touched on all these. I just love recovery management checkup. It's just, again, chronic care model. You got to love that one. Shared decision making, not new. What is new? Preliminary treatment plan. Sometimes we might reference it as the initial treatment plan, which is that based on the levels, the dimensional drivers that got the person into care. And then we have time to develop the ongoing treatment plan. They have specific universal characteristic standards and universal documentation standards for all levels of care. Very specific. You could almost write regs. I've been saying forever, ASAM's not regulatory, ASAM's not regulatory, which is really good. I'm not sure we want it to quite be regulatory, but it's so specific now that people who have to write regulation are going to have a much better foundation for regulation and contractual expectations of how you use the ASAM criteria because of the specificity they've offered in the universal characteristic standards, documentation standards, and then those are even broken down further, as I mentioned, for co-occurring enhanced services, trauma-informed care. There's additional specificity when we think about what needs to be in a program. The term should consider and may, or just kind of a runoff of what I just talked about, and they identify things that should be done or that you should consider or that may be done. So obviously the shoulds, sometimes we use that in a negative connotation, but here I'm going to twist it positive. The should is obviously a more powerful expectation in the ASAM criteria. And PROMS, just because it's another new acronym for some, patient-reported outcome measures, which goes into the measurement-based care aspect. And additional discussion about recovery residences, which I've already touched on. Wow. Valerie, I would like your consultation. We have 7
Yes, hello.
Hi. We have 7 minutes. What do you think?
Let's answer some questions. I just want to say, first of all, thank you so much, Scott, for this really informative presentation. A lot of really good questions have come in, both in the registration process as well as in the chat today. We will unfortunately not be able to get to all of those questions. So again, if your question hasn't been answered in today's webinar, we do encourage you to email support@trainforchange.net. That's there on this slide, because we would absolutely love to continue this conversation with you and get to more of these really meaningful questions that you've posed. So let's see if we can get to just a couple today. We've handpicked a few. The first one comes from a person who's worked in a number of programs across different US states. And this person's observed that they all used the ASAM criteria differently. So the question is, what is ASAM doing in this next edition to address fidelity?
I told her not to ask me any hard questions, but yeah, thanks, Valerie. Thanks for the help. Stump the trainer. So what's ASAM doing? I don't know. I don't work for ASAM. But what I do know is historically the ASAM criteria, and I think one of the shortcomings of the ASAM criteria, potentially ASAM, is there hasn't been clear measures of what it looks like to implement the criteria. There hasn't been a tool, structures. How do we measure it? As Peter Drucker says, what's measured is improved. And we never had clear measures, and the book, again, wasn't specific enough to offer us measures. So one of the things they've done, they've gotten much more specific in the criteria to help. This is what ASAM criteria looks like when it's being used, coming back to the should and the maybe and the universal characteristics. That's going to help. They've developed this incredible ASAM criteria implementation guide, which doesn't give you all the specific measures of what it looks like to use the ASAM criteria, but it offers us a tool. We've mastered sending people to training and expecting them to change. As a training organization, we know that typically is only one tiny piece. So the ASAM criteria implementation guide is a structure to help with installing it. How do we install this thing we learned? And it's based on NIATEC's model, science-based implementation strategies, evidence-based implementation strategies within the ASAM criteria implementation guide. So let's use evidence-based implementation strategies to implement evidence-based clinical services. And then also with their CARF certification, there's much clearer measures and specificity for the residential levels of care. So those are three things off the top of my head that are really going to help with continuity. And then there's this thing called the continuum, the software, which it helps with consistency with a biopsychosocial assessment. So we're getting consistency at that level also. Not all providers are using that at this point in time, but it's another piece that can help with. I'm using the continuum in San Diego, and we're using the continuum in Harrisburg. Hi, Tim. Harrisburg, Pennsylvania. So we're getting continuity. So those are a few things. No have-tos, but a few things that might be of value.
Great. Tim just said hi in the chat. So FYI, he's here. Hello, Tim. The next question, I think you'll enjoy this one, Scott. Someone's asking, what are the best revisions and additions to the 4th edition? I imagine different people may have different answers to this question, but Scott, let's hear what yours are.
And again, I got to qualify this with super, super subjective. Blending 3.3 level of care, folks with cognitive needs across all levels of care, and eliminating 3.3 is key. Level 1, chronic care model. So that level 1, ongoing remission management is huge. Dimension 6 is awesome. I mean, just the value of Dimension 6 and understanding, working with people to understand the most appropriate level of care, potential barriers, and seeing, it just gives us such a greater opportunity and structure to get beyond externally motivated, court mandated, non-compliant. It just gives us a whole structure to understand people and document people as people rather than people as what got them to treatment. Sometimes we turn the people we serve into a mandated client or court referral, and there's so much more to them than that. And I think we know that, but we don't always have good structures to help us articulate that in language and or documentation and collaboration, which a lot of these things are intuitive for clinicians, but now it's like, hey, here's this better support to possibly do what you're already doing.
Perfect. I think that is it for our time. So let's just jump to the next slide really quick and wrap up here. Thank you so much, Scott, again, for answering those questions and for this really great overview. For those who are attending this webinar live here with us today, we will be sending you a downloadable PDF and a recording of this webinar, along with a lot of you have expressed interest in continuing to learn about what's coming, trainings that are being developed. So we're going to give you an opportunity to sign up to be the first to learn about 4th edition trainings and any additional resources coming soon from the Change Companies and Train for Change. So watch for that in your inbox within the next 24 hours, and hopefully we can stay in touch with those of you who are interested in continuing to learn more and continuing the conversation. Let's jump into the next slide, and this is going to have our joint URLs. Please visit us at changecompanies.net or trainforchange.net to continue to get to know us better. Give us a call. We'd love to, again, continue the conversation. And thank you all so much for joining us today. Take care, everyone.